الخير. أنا دكتور خليل الحصري، استشاري أمراض دماغ وصرع. بنحكي اليوم عن ال Treatment of Status Epilepticus. خليه يكون هذا interactive as much as possible، واحكوا لي إذا الأدوية مش موجودة أو موجودة وإيش أنتوا كيف. بدي أسمع منكم كمان شو what's your practice as well. نأخذ إنه كيس بسيطة. Miss Smith, 29-year-old woman, has been admitted to the internal medicine service with abdominal pain. Okay, so she received a diagnosis with idiopathic generalized epilepsy when she was 8 years old. So she already has epilepsy. She takes levetiracetam, which is Keppra, at a dose of 1,500 milligram in the morning, 1,500 milligram at night, which is 3 grams a day, which is a good dose. And her most recent seizure was a year ago. At 2 a.m., you were called emergently to the bedside to evaluate Miss Smith, as she's been having a generalized tonic-clonic seizure. Upon arrival, Miss Smith has been convulsing for about 5 minutes. Okay? So what would you do next? How would you treat Miss Smith? Would you give her levetiracetam 4.5 grams IV? Would you give her lorazepam 0.5 milligram IV, lorazepam 2 milligram IV, or I'm not sure? What would you guys give?
lorazepam
2 milligram, exactly. خلينا أشوف give me 1 second أحط البوينتر laser pointer بالضبط. So lorazepam 2 milligram, exactly. So هذه البيشنت عندها something called status epilepticus. So status epilepticus, you know, the simple definition is that it's a prolonged seizure. So it's a seizure that fails to stop on its own, okay? So we did the studies that showed that almost 95% of seizures, they last approximately up to 2 minutes. So approximately 120 seconds to 160 seconds. Most of the seizures, they will stop of the brain. And the brain itself, it has inhibitory components that will stop the seizure. However, we have status epilepticus is a condition that results either from the failure of those mechanisms that are responsible for the seizure termination, or it's for the initiation of the seizure, it gone, you know, out of whack, okay? This leads to an abnormally prolonged seizure. And this is, we call it a time point 1 or T1. Now, it does have long-term consequences, including neuronal death, neuronal injury, and, you know, alteration of the neuronal networks. And this happens at time point 2 or T2, okay? Now, we have this time 1 and time 2, it's more of a theoretical time, but we think of it as T1, the treatment should be initiated, and then T2, it's where we think the long-term consequences, they may appear, okay? So what is time 1 and time 2 usually in status epilepticus? Now, we have different types of status epilepticus. The most common type, or the most, you know, well-known type, is a generalized tonic-clonic status epilepticus. So in a generalized tonic-clonic status epilepticus, treatment should be started within 5 minutes. So at T1 is at the 5 minutes. From animal studies, we think that T2, it's usually at 30 minutes, okay? So within 30 minutes, more than 30 minutes, long-term consequences and neuronal damage and neuronal alteration will start after 30 minutes. Now, if we have something called focal status epilepticus with impairment of consciousness, so it's not a generalized tonic-clonic status, however, it's a focal. The T1 is approximately 10 minutes, and then T2 is approximately 6 minutes. Now, in patients with the generalized epilepsy, they could have absence status epilepticus, and T1 is approximately 10 to 15, and honestly, T2 is unknown. Sometimes these patients, they go into days of status epilepticus, and they recover well after treatment. So we're gonna focus on generalized tonic-clonic status epilepticus because it is the most well-studied, and also, you know, it's the classic and the most severe form of status epilepticus. Hala, we divide status epilepticus into 2 big groups. One of them is called with prominent motor component, and the other one is called with a no prominent motor component or non-convulsive status epilepticus, okay? The prominent motor component, it depends on what the patient is doing. So what are you seeing? We have a convulsive, we have myoclonic, focal motor, tonic, and hyperkinetic. And the convulsive, it could be either a generalized onset, focal to bilateral, unknown onset, and the same thing with the myoclonic. So myoclonic with coma, we usually see it in post-anoxic injury, okay? Myoclonic without coma, we can see it in patients with juvenile myoclonic epilepsy. Now, in non-convulsive is the same thing. So it means that the patient is having status epilepticus. However, the patient does not have a prominent motor component, okay? Now, at the end, almost all of status epilepticus, you will never continue to have a convulsive status epilepticus. At some point, the status epilepticus will turn into a non-convulsive status epilepticus because you will have something called a cerebro-clinical dissociation. So the brain will be seizing, but the body, it will dissociate, and you cannot, they will stop seizing. It will tire out, okay? So this distinction is mainly at the beginning, at the early stages of the status epilepticus. So the same thing for the non-convulsive or without a prominent motor component, we divide them into generalized, we divide them into focal, and we divide them into also an unknown as well. Now, how are we going to treat these patients? So the American Epilepsy Society, they published some guidelines a few years ago, and it tells us, how to treat them. So from 0 to 5 minutes, which is the stabilization phase, which is the early phase of the status epilepticus, the most important thing is to stabilize the patient. Because remember, most of the seizures, they will stop on their own, right? About 95% or 98%. So stabilize the patient. It's the ABCs. Make sure that they are, the airway is protected, breathing, and the circulation. Time the seizure and monitor the vital signs. Assess the oxygenation. If needed, give oxygen via face mask and nasal cannula. Put the patient, on left lateral decubitus, okay? And then the important thing is to make sure that the fingers take, the glucose. So make sure the patient is not hypoglycemic. And then attempt IV access, consider electrolytes, and then a blood level if you want to. And then start an ECG monitoring. So this is in the house, or by a trained paramedic, okay? Now, if the patient continues to have seizures, so now we are almost at 3 minutes or so, so then you're gonna start medications. So you have a lot of options to give, and we're gonna talk about the studies that did that. So you can either give intramuscular midazolam, so 10 milligram, or you can give intravenous lorazepam, which is 0.1 mg per kg per dose, or you can give intravenous diazepam as well. So it depends if you have an IV access or if you don't. And if none of these are available, you can give intravenous phenobarbital. You can give rectal diazepam. We use it in kids a lot. And intranasal midazolam. It's a new thing over the past few years where we have several intranasal midazolam now. Any questions? Okay, so the first line treatment for status epilepticus is benzodiazepine. And this actually, it came from an old study published in the New England Journal of Medicine. It's called the VA status epilepticus study. So the VA is the Veteran Affairs, which is, مستشفى العسكري اللي هم it's like المدينة الطبية بعمان. And what they did is that they randomized patients. So approximately about 518 patients. So about 400 of them, they had overt status epilepticus. And they randomized them into patients getting lorazepam, phenobarbital, or diazepam and the phenytoin, which is dilantin, or phenytoin alone. What looks like among the 4 groups, there was a difference. The biggest difference was between lorazepam and phenytoin, as you can see. So there's here we have, 64.9 in the overt, and then 43%, and it was statistically significant. There was no difference between the others. So in this study, we showed that intravenous lorazepam is superior to phenytoin as a first line in the treatment of status epilepticus. بعد هيك سووا another study. And this study, what did they do is that they looked at lorazepam versus diazepam, and this is out of the hospital treatment. So this is one of the earliest study that looked at, can we treat status epilepticus قبل ما يجوا على المستشفى, before the hospital, okay? And it was about 205 patients, and they randomized them into either lorazepam, into either diazepam as well. Both of them, they worked fairly well. Here is about 59%, and here is about 42%. So half of them, they stopped the seizure. More importantly is that this study, it showed that giving benzodiazepine outside the hospital is actually safe, because there was a concern that these patients, they will go into cardiopulmonary, compromise. However, it showed that it's actually safe. It was 10% in the lorazepam group, 10% in the diazepam group, and look how much, 22% for the placebo group. So seizures itself and status epilepticus itself, it will cause, respiratory and circulatory cardiovascular complications, and not the medications. The next study is the rampant study. So it's also, now they started to do intramuscular midazolam and intravenous midazolam. And this is the same thing that we're looking here. So a couple of these studies that showed that benzodiazepine, including either IM or IV lorazepam or IM midazolam, was successful in treatment of status epilepticus with low risk of cardiorespiratory compromise. Now in kids, they did something called, it's mainly in kids, but they did rectal diazepam now. So they randomized 91 patients to rectal diazepam, about 47 children, 44 adults. And look at the difference between the diazepam and between the placebo. There's a big difference between those who received it or not. And clearly rectal diazepam also works for patients with status epilepticus at the outside setting. So on summary, with the benzodiazepine, we showed that intravenous lorazepam and intramuscular midazolam and rectal diazepam, all of them, they are, they are considered to be first line in the treatment of status epilepticus. Now, a little bit of initial evaluation of status epilepticus. All of the patients, they should get a finger stick glucose. This is very essential, okay? We wanna make sure that the patient are not hypoglycemic, because it's very, very easily corrected hypoglycemia. You should monitor the vital signs. Get a head CT if needed, appropriate for most cases. If a patient with, with a history of epilepsy presenting with status epilepticus, probably, it's not 100% necessary to obtain a CAT scan or a head CT. Order laboratory test, blood glucose, CBC, basic metabolic panel, calcium, magnesium. If you can get anti-seizure medication or anti-epileptic drug levels. EEG, depends if you have the capability to do it or not. Same thing with the MRI and the LP. These are all depending on the clinical presentation of the patient rather than on every patient. Now, what's so urgent? Why do we care so much to treat status epilepticus so urgently? Because remember, there is a cascade of events that happens from a single seizure into a status epilepticus. So stage 1, which is about within a few seconds, we will have, protein phosphorylation, we'll have ion channel opening and closing, and we'll have also neurotransmitter release. At stage 2, within minutes, then we will have receptor trafficking. Look here, we will have decrease in the GABA. Remember, how does the benzodiazepine work? They work on the GABA receptors, right? And what happens in prolonged status epilepticus is that the GABA receptors, they will be internalized. So this will make the benzodiazepine less effective in later stages of status epilepticus. So so that's why it's important to treat early and to prevent this snowball or the cascade of events to happen. Okay, we'll have also increase in the excitatory NMDA receptors and increase in the excitatory AMPA receptors as well. Within minutes or hours, we will have neuropeptide expression. We will have increase in substance P, and also eventually we will have genetic and epigenetic changes with gene expression, DNA methylation, and deregulation of microRNA. Okay, so it's a sequence of events. Treatment, it will prevent and it will stop these sequences from happening. This is also another image that it shows what we talked about. So NMDA receptors, they're usually upregulated in status epilepticus. On the contrary, the GABA receptors, they are actually internalized. So here we have the GABA receptors. It will be internalized, you know, as the status epilepticus progress. So this, you know, you will have lack of the inhibition, and you will have increase in the excitation from the glutamate and the NMDA. And this is, you know, a recipe for just continual seizure and seizure. So is there any studies that actually showed that time is brain, that a delay of status epilepticus will give you worst outcome? There is. In one study, for every minute delay from the convulsive status epilepticus onset to the arrival at the emergency department, there was a 5% cumulative increase in the risk of having a status epilepticus that lasted longer than 1 hour, right? Another study shows that untimely administration of benzodiazepine more than 10 minutes was independently associated with in-hospital mortality. And this is after adjusting for multiple factors. So it is both clinical and both from, you know, from the lab, we have evidence that time is brain and in status epilepticus, and the longer you wait, the worse the outcome. Now let's go back to our patient. So our patient still seizing after giving 2 milligrams of intravenous lorazepam. She continues to be hemodynamically stable with stable vital signs. So what do you do next? You give another 2 milligrams. Remember the guidelines, it says up to 4 milligrams. It's 0.1 mg per kg. I usually don't give the 4 milligram immediately. I usually divide them into 2 and 2. So I wait like a minute and then and give it 2, because the problem with the 4 milligram is patients, they will be severely sedated with 4 milligram of the lorazepam. Okay, you will alert, you know, the ICU or, you know, or the step down unit for possible transfer. You should order an anti-seizure medication and then do some blood work as we discussed before. Any questions, guys? Okay. So the same thing. Miss Smith, another Miss Smith, she's 29-year-old who brought to the emergency department after having a tonic-clonic seizure at a party which she consumed alcohol. Paramedics, they came and they gave her 10 milligrams of IM midazolam, which terminated the seizure. However, she remained unresponsive. Okay, now 5 minutes after arrival to the emergency department, she had another tonic-clonic seizures, and these seizures have recurred in brief and abortive forms every 5 to 10 minutes. So she kept having non-stop seizures. Now, her vital signs are okay, and she's, you know, breathing normally, 98% on a high flow oxygen. So, you know, tenuous. So how would we treat this patient now? Should we give her fosphenytoin, which is which is a dilantin, levetiracetam, or valproate, or any of the above? I'm sorry. Yeah. So actually, the A is correct, but any of them works actually. So any of the 3 of them, they work. And now let's go back to the second tier or the second line. So we're done with the first line, which is the benzodiazepine. Now let's talk about the second line. The second line, you choose one of the following. So either intravenous fosphenytoin and you give 20 mg per kg, intravenous valproic acid, 40 approximately, intravenous levetiracetam or Keppra, 60 mg per kg. The way I teach it is that it's 20, 40, 60, so it's very easy. The maximum dose of phosphonatoin is approximately 1500, intravenous valproic acid 3000, and the Keppra is 4.5 grams. If none of the options are present, you can give intravenous phenobarbital as well. Okay, what do you guys have in the ER? Which medications? All of them? ايش هو؟ بس how about Depakote, valproate? oral. Or how about Keppra?
هو الكيبرا اللي عندنا ليفيتارستام عندنا بس هو الكيبرا بس اللي عندنا.
طب ودايلانتين ما عندكم؟ مش معقول.
عندنا فينيتون.
فينيتون. اوكي جود. اوكي فينيتون اي في صح؟ Okay, so either phenytoin IV or dilantin. So phenytoin or phosphonatoin. So phosphonatoin is a prodrug of phenytoin. So phosphonatoin, they added a phosphate group على البنزين ring تبعت الphenytoin, and that's why it became less acidic. I'm sorry, less alkaline. عشان هيك it has less cardiovascular side effects or less phlebitis. So that's the advantage of the phosphonatoin. So that's fine. I mean, they are equally effective. It's just phosphonatoin is less side effects. Yeah. So then you can use either intravenous dilantin or intravenous Keppra, either one of them. Okay. And we're going to talk about which one. Show evidence, what studies they have shown. So there have been a lot of studies that looked at a lot of small studies and retrospective studies that tried to answer this question. So from the 1990s, okay? And eventually, 2 years ago, we had a big study that really answered that questions. This is just a summary of the several studies that, and you can see almost all of the results, they are usually comparable. Depakote is comparable to phenytoin, it's comparable to Keppra, it's about the same, right? No difference. So all of them, they are almost about the same. We're going to focus about this study. This study is called the ESET trial. So Established Status Epilepticus Treatment Trial. It was published in the New England Journal of Medicine in 2019. This was a large, multi-center, randomized, double-blinded trial. They randomized about 400 children and adults with benzodiazepine refractory status epilepticus. So all of the patients, they already got the benzodiazepine. Now we're going to talk about which one is better out of these three. So we have levetiracetam, the Keppra, the phenytoin, and then the Depakote or the valproate, okay? And the doses that they used, 60 mg per kg, 20 mg per kg, and then 40 mg per kg. And their goal or their outcome is absence of clinically evident seizures and improved responsiveness. The patient now is waking up at 60 minutes after the status epilepticus. And look here at the difference. There was no difference whatsoever, right? Here about 47%, 45%, and 46%. So about half of the time, any of these medications, they work in stopping the status epilepticus. And this is after giving lorazepam. Let's dig deep into this a little bit. I just want to emphasize most of all of the characteristics, they were fairly similar between the three groups, between the Keppra, the phenytoin, and the Depakote. And I just want to emphasize here that the median lorazepam dose was not very high. Look, this is a cumulative. The dose is approximately 4 to 6 mg per kg, and the same thing here. And the median duration of the seizure enrollment, look, it took them approximately an hour to enroll the patient from the onset of the status epilepticus. Okay. Let's talk about the admission to the ICU. About 60% they went into the ICU, as you can see. And let's look at the side effects. The intubation was a little bit higher with the Dilantin, about 26%, compared to 20% in the Keppra, and then 16% in the Depakote. But it was not statistically significant outcome. Okay. Now, do you guys have Vimpat or lacosamide?
No.
Okay, so we're not going to talk about it. So this is a summary. Do you guys want to talk about it?
No.
Yeah, it's a fairly new medication over the past 20 years. It's a focal medication. It's very good for focal epilepsy and focal seizures, Vimpat or lacosamide. Usually we give it at a dose range of 200 to 400 milligram. It's fairly minimal interaction with other drugs. No blood level is needed. The only thing is that you need to remember is that it can cause some bradycardia and first-degree AV block. Okay, so in a patient with high-risk cardiac patients, you need to do some EKG monitoring during or while giving the Vimpat or the lacosamide. Okay, so that's the most important side effect for it, is it can cause bradycardia and first-degree heart block. Okay, it works on a sodium channel, so it's fairly, it's a little bit better than Dilantin, much less side effects, much better tolerated than Dilantin. So a little bit of comparison between the phenytoin, between the Depakote, the Keppra, and also the Vimpat. So the phenytoin, the dose, remember, is 20 mg per kg, and we give a max of 1.5 or 1,500 milligram. The standing dose is usually 300 milligram per day. You need to have some sort of cardiac monitoring while you're giving it, especially with the IV load, especially when using phenytoin. It's usually slow administration. You got to do it over 20 minutes. Fast administration will give you phlebitis and will give you also some hypotension as well. And this is from the glycol. The ethylene glycol is where the phenytoin is preserved in. You see the side effects is hypotension, bradycardia, and arrhythmia. Avoid in patients with porphyria. I mean, it's very rare. And you gotta be cautious in patients with the generalized epilepsy as well, because it might make generalized epilepsy worse. Remember, it's a focal medication. It works on sodium channels. It has higher risk of intubation, higher risk of hypotension as well. And it does have drug-drug interaction, and there is teratogenic. Now for Depakote or valproic acid, it's about 30 to 30 mg per kg and the max of 3,000. And the maintenance dose is about 2,000 milligram per day. It doesn't need any cardiac monitoring. Remember, you can't give it younger than 2 years old. Do you know why? Depakote, we can't use it بالأطفال أقل من سنتين. كيف؟ مش سامع.
gingival hypertrophy وكيف abnormalities.
Yeah, so Depakote it's oxidized, it's metabolized by the mitochondria, and it's metabolized by it's the same thing as the fatty acids. So if the patient has a POL-G mutation, which is one of the mitochondrial disorders, they can go into hepatic failure, and they will die. And sometimes these are not discovered actually up until 2 years of age. So that's why we don't use it in younger than 2 years of age. Depakote can cause hepatotoxicity, remember, and hyperammonemia. It's the best one probably in generalized epilepsy. And it does have a trend with less intubation, as we showed, and less or shorter seizure duration as well. Keppra or levetiracetam is 60 mg per kg. You need to give a good dose. You need to give about 3 to 4 grams of Keppra. A lot of people, they only give 1 gram of Keppra. It does not work. You got to give a good dose, okay? It's a 40 to 60 mg per kg per day, I'm sorry. You don't need cardiac monitoring. You can give it fast. It does cause drowsiness. It's a sedating medication. It does cause agitation as well. And it's slow to cross the blood-brain barrier. It does take about, maybe half an hour to peak in the CSF. So remember that. It has a low risk of intubation, low risk of hypotension, and minimal drug interaction as well. And the Vimpat or lacosamide, it's the same thing about the bradycardia and the dizziness. It can cause bradycardia as well. And you need to consider cardiac monitoring in high-risk cardiac patients. Okay. One of the old medications that we still use is the phenobarbital. We don't use it as a first agent. Phenobarbital is a GABA A blocker. It does have some AMPA, which is calcium antagonism. It's 95% bioavailability. It's a medium protein bounding. And then the half-life is long half-life, about 100 hours of half-life. It is hepatically metabolized. Okay. Phenobarbital tends to be very good in neonatal. So it's first line in neonatal seizures and neonatal status epilepticus. And also we use it in super refractory status epilepticus. So after we fail several medication, then we use phenobarbital. It's extremely sedating, of course, and it does have a lot of drug-drug interaction. Of course, do you guys use it much, phenobarbital? لا.
No.
Okay, so maybe بالأطفال. بالأطفال, I mean, we use it a lot. I mean, it's very old medication. It's one of the first medications for anti-seizure medication. We use it a lot in neonates. Other than that, قليل نستعمله لأنه a lot of side effects, very sedating medication. Okay, let's talk a little bit about the causes of status epilepticus. So if a patient has epilepsy, the most common cause actually of status epilepticus is a low concentration of anti-seizure medication. So that's about 34% of the cases. They have a low, they have a low concentration of anti-seizure medication. And then other thing is that alcohol misuse, tumor very rarely, idiopathic we don't know. You have remote symptomatic. And if you have an acute status epilepticus, this is the first time. So stroke, metabolic abnormalities, hypoxia and anoxia, systemic infections, trauma, drug overdose, CNS infections, meningitis, encephalitis, and CNS hemorrhages as well. And the mortality of status epilepticus, it depends much about what is the etiology as well. As you can see, a patient with chronic epilepsy who presented with low concentration of anti-epileptic drugs, the mortality is about 4%, compared with a patient with stroke is about 33%. Hypoxia and anoxia is about, 70%. So it's a very high mortality. So it's very much, depending on what is the etiology of the status epilepticus. Okay. Let's show you a little bit of let's do a little bit of a practical questions here. Okay, we gave the patient Dilantin, okay? She received Dilantin about 20 mg/kg at 10 a.m. The seizure stopped. You decided you wanted to start a maintenance dose of 100 mg TID of phenytoin. When would you schedule the first maintenance dose? 12 p.m., 10 p.m., 3 p.m., or you get a blood level at 12 p.m. and then you decide. What do you guys think?
I think T.
Which one?
T, based on the level after the first dose.
Yeah, exactly. It is. So let me explain to you, Leish. Absolutely. So remember, Dilantin, it has a special pharmacokinetics. It does not, it follows, this first order kinetics. So what they did here is they have 20 children and they gave them all about 18 or 20 mg/kg IV phosphoenetone. And then they measured level at 2, 6, and 12 hours. So what they found is that all patients had a level more than 10, which is therapeutic, at 2 hours. 50% had a level more than 10 at 12 hours. What they looked at is that mean 2-hour level in the therapeutic group was 22.7 compared to 15.6 in the subtherapeutic group. So you check a blood level at 2 hours after the dose. If this was good therapeutic, then you can do it, you can wait up to 12 hours. إذا كان أقل, then you gotta do it before حتى to prevent the dilantin from dipping down. And then you can do this equation, which is the level that you obtained ناقص 10 over the mean decline in the phenytoin, which is approximately 0.7 to 1, so which is approximately 1. So just يعني إذا كان level about 15, so 15 ناقص 10, it will be about 5 hours from the time that you give the initial dose. إذا كان level, for example, 22, so then you do it 12 hours after. Understood? Okay, another question. The post-load level of the phenytoin was 13. You called me وأنا قلت لك push it towards 18. Okay? How much more phenytoin would you give? Is the patient weight is 70. So what's the equation? So let's calculate it. So we wanted 18, okay? Let's go back. So the target level, which is 18, minus the current total phenytoin level, which is 13, so that's 5, times the kilogram body weight, which we said is 70, so 5 times 70, times the volume of distribution. For phenytoin, the average volume of distribution is about 0.8. For Depakote, it's the same equation, but you gotta change the volume of distribution into 0.2. Okay, so 18 minus 13, so that's 5. 5 times 70, let's do some math. So 5 times 70 is 350 times 0.8, so 280. So it's B. So you give an additional 280 milligram IV, and this will push the level up to 18, approximately. Any questions? Okay, let's a little bit talk about what happens if the seizure persisted. So we give lorazepam, we gave dilantin or Keppra, but the patient's still having seizures. In that way, we call it refractory status epilepticus. Refractory status epilepticus is defined as a status epilepticus that persists despite the administration of at least 2 parenteral anti-seizure medication, including a benzodiazepine. There's no specific seizure duration. Now, super refractory status epilepticus is defined as status epilepticus persisting at least 24 hours after the onset of anesthesia, either without interruption or recurring while on appropriate anesthetic treatment. Okay, prolonged refractory status epilepticus, it lasts for 7 days, and prolonged super refractory, it's in the needs of anesthesia. Now, how often? About 15 to 22% of status epilepticus, they progress into refractory status epilepticus. So you know about 1/5 of them. And of those, about 22% continue to super refractory status epilepticus. So how are we going to treat patients with refractory status epilepticus? So we gave them the benzodiazepine, we gave them the Keppra or the dilantin. Now they are still seizing. How are we going to treat them? Unfortunately, there's no guidelines. We don't have any good studies that looked at what to treat with, but it's usually with anesthetics. So at this point, you gotta intubate the patient and you gotta start IV anesthetics. So we have a lot of options. And honestly, there's no good studies that compare them head to head. So options include intravenous anesthetics. We used all, and in super refractory status epilepticus, we've used immunotherapy, ketogenic diet, neurostimulation, hypothermia, pyridoxine, surgery, you name it. But in general, these are usually the doses. We usually start either with midazolam or propofol, okay? They are usually the first line treatment, midazolam, propofol. If the patient continues to have seizures, then we'll go into pentobarbital. And then more recently, in the past several years, we've been using ketamine IV as well as a second line. The advantage of the ketamine is that it does not have cardiovascular depression. It doesn't cause hypotension, bradycardia, and so on. Okay, and ideally, this patient, they should have, frequent EEG monitoring when patients with super refractory and refractory status epilepticus. Okay. That's all I have. Any questions for you?
Does fentanyl or fentanyl increase the risk of seizure?
Oh, fentanyl. It does not. It doesn't treat seizures for sure. At usual doses, it does not increase the risk of seizures. No.
يعني higher doses ممكن تزيد the risk of seizure?
Very minimal. I would say no even. Like, I mean, if you have it for a drug abuse, like, I mean, some patients, they use fentanyl as, like a drug addict, then yeah. But like we use it in the hospital, no, it doesn't. What other questions?
شكرا حكيم على المحاضرة.
يا هلا. أي أسئلة تانية؟
Thank you.
أوكي، شكرا guys. يعطيكم العافية.
حكيم ممكن ترفع لنا المحاضرة على الجروب؟
يا ببعتها لرامي. Yeah, of course. ببعتها لرامي وهو ببعت لكم إياها of course.
بصراحة في محاضرة كثير حلوة كلنا استفدنا.
يا هلا. يلا يعطيكم العافية وسلام للجميع. هلا. باي.
Oh,